So it's my pleasure today to introduce you to three excellent orthopedic surgeons and doctors who have been working with the Family Hope Center for the last 25 years. I'm very blessed to have these folks working with our team because they're here to empower our parents, teach our parents about functional orthopedics, and to empower you with information and to teach you from the bottom up and the top down how the structure works and what good function looks like. As you know, with children with special needs, children with neurodiverse issues, the structure of the hips, the structure of the feet, the structure of the spine, the shoulders and neck can get compromised from their neurological complications. And what we at the Family Hope Center want to do is partner with our orthopedic surgeons to support families to have excellent organic function. I have been working with Dr. Joe Pasciati, who I'd like to introduce right now. Dr. Joe has been working with our team for 25 years. I met Dr. Joe through an infomercial, matter of fact, because I was looking for someone who could really help our children whose feet were turning in, feet were turning out, hips were dislocating, the spine was misalignment, and they needed somebody who really understood the neurology and the orthopedics and to bring that together. So I met Dr. Joe. We had lunch, and he joined our team over 25 years ago. And we have traveled around the world. We've been in multiple different continents and seen thousands of children. Dr. Joe, come on up. Let me introduce you. And we have become good friends, but also excellent colleagues. And we have seen a lot of children together. I look at the neurology. Joe looks at the physiology and the function and the support of the body. And we work as a team, always discussing what is in the best interest of this child, what's in the best interest of his feet, his hips, his spine. And together we develop strategies and plans that we teach the families, we teach you how you can support your family. So you're going to hear from Dr. Joe today, and it's great to have you.
Thank you, sir.
Yes,
Thank you.
Excellent. Next, I'd like to introduce Dr. Brett. Dr. Brett Pasciati is the son of Dr. Joe. He's learned a lot from his father. Probably
Absolutely.
had to unlearn some things from his father over time. But Dr. Brett is a doctor of osteopathy. He's an expert in musculoskeletal development. He teaches, he empowers families, he empowers people. He works out in Florida, but thankfully, because of the internet, we have a lot of communication back and forth. We talk a lot about kids with scoliosis, kids with the hips that are dislocating. He's innovating. He's on the next cutting edge. Our whole team is on the cutting edge. We're trying to figure out ways which we can really support and empower families to get to that next level so that we don't go down pathways that are going to be not supporting the overall neurological and structural health. So Dr. Brett has been working with us for a number of years, and we like having part of the team.
Thank you.
Excellent. Yes.
Good to be here.
Next, I'd like to introduce Dr. John. Dr. John is the head of surgery at a hospital in New Jersey, and he joined our team about 1.5 years ago. He's good friends with Dr. Joe, and we really like having more knowledge. They say that if you're smartest man in the room, you're in the wrong room. And what I like to do is bring really smart people on board that all three of us, plus our team, can be looking at the same child at the same time and say, what would we do to support this child's function, structure, to help continue the neurological development. So it's really, really great to have you as part of the team.
Pleasure.
We've been seeing families together, and we're talking and talking, listening to families, listening to your concerns about your children, and coming up with proactive organic solutions to support them. And yeah, we're always looking for ways to support the family. So it's great to have you.
Thank you, Matthew.
Now I want to have Joe come back up and go through the slides along with Dr. Pasciati, his son, and to discuss the orthopedics.
So I guess the next question is, now that you've met all of us, is why are we here? And I can tell you a little bit about why I got into medicine. Number one, it's because Dad was a doctor and Mom was a nurse. So naturally, I guess that's what I was going to do, obviously. And why did I go into osteopathic medicine? Osteopathic medicine because it was more of a holistic approach to healthcare, which is what I was really interested in. And then the other reason is because, again, osteopathic medicine, there's some tenets there, right? What are the tenets? So the body has the ability to heal itself. The body is a unit, and we think that structure and function are related. So structure can obviously affect function, but function can affect structure as well. So what are we going to do here at the Family Hope Center as part of the bigger team? We're going to do comprehensive assessments, right? Looking at orthopedic conditions, but also just musculoskeletal health in general, right? And so we're going to look from the top up and the bottom down at everything, not just one particular thing, not just the foot, not just the hip, not just the knee, everything and how it relates to all factors of a child's health. All right, we're going to do gait and postural optimization, and we're going to kind of work collaboratively, integratively. And again, we're going to look at all components of health, not just one particular thing. And we're also going to try to avoid unnecessary surgeries and things like that in certain instances. All right, so hopefully we can preserve joint health, we can prevent surgical interventions that possibly can be destructive to joints, and we can help patients and their families and the kids. That's why I got into medicine, and that's why I'm happy to be here, and I'm thankful that Matt has me as part of the team. Now let's bring Dr. Joe in. Let's bring Dad up, and he can talk specifically about the foot a little bit here and some things that may relate to your family.
Thank you, sir.
Yep.
So let's talk a little bit about foot function and structure and how it affects the rest of the body. Pronation, which is a collapse of the foot itself, is one of the most destructive forces that can affect the body. If you look at the three examples on the side there, there's supination, a normal foot, and then pronation. Supination is when the foot is turning up, it's like a high arch foot, and pronation is when the foot collapses. It's a very destructive force that unlocks all of the muscles and tendons and joints in the foot, and only travels, it only affects the foot and the ankle, but it affects the knees, the hips, the joints, superior to that as well. The solution that we provide, the safest and simplest solution that we provide, is the use of orthotics. If you look at the slide up here, you'll see on the one side the body is in a normal position. Everything is correct with the position of an orthotic. And you'll see on the left side how the body is affected when the medial arch is collapsed. You see it affects the knees, the hips, the back, the neck, everything. So, how do we do orthotics? Well, we take an impression of the foot. We formulate an orthotic to put the foot back into the anatomically correct position so that the structure improves, the function improves, and overall body improves. What are the impact of orthotics? Orthotics put the foot back into the anatomically correct position so that the muscles and tendons function properly. I'm going to ask Matthew to come up for a second because we are of the understanding that when you put the foot back into the correct position and the function is better, the structure is better, that it affects the neurology as well. Matt, can you explain that a little bit for us?
So you have all these muscles, ligaments, and tendons in your body. You have over 26 bones in your feet. You have over 33 muscles. You have 112 ligaments. You have 33 joints. So your foot is incredibly complicated. And when Dr. Joe talks about our children walking on the outside of the feet or the inside of the feet, this is extremely common for our children because, as you know, through the parent training, they're not crawling and using their reflexes. They're not crawling through their feet, so they're not developing their feet. And so we had the children who are 3, 4, 5 years old, 12 years old, 15 years old. Their feet are turning in, they're turning out. And so you have all this structural complications. And with Dr. Joe and his team, with the use of his measuring tools, put the foot in the right position so all of these joints start happening. And what we see changes in the balance. Because of the fact that the bones are not happy down here, they're not going to be happening in the cranial bones. We did talk about craniosacral therapy before. You have 23 bones just in your head itself. So what happens is balance changes. Children get better balance down here. It changes the Babinski reflex, the tendon guard, the trunk extension, the Perez, the Gallant reflex. It changes their whole tonic neck reflex. So we see actual changes in balance because these temporal bones shift and the inner canals of the ears, which support the balance, the semicircular canals, they open up. And we see that children can then have these reflexes, like the head riding reflex, come online because of the changes. So we see changes in the children's nutrition. They're not irritated anymore, so they're not nauseous anymore, so they eat a little bit better. You know, the semicircular canal also can make you dizzy. If you're not really focusing on it, you can be dizzy although you don't eat very well. So we see changes in digestion, changes in your intellectual capacities. They don't have headaches as much as they used to be. So we're working, as Dr. Brett said, in a collaborative way to bring about the functionality orthopedically and the neurology.
Thank you. Thank you. So with the development of gait study centers where you walk over a force plate and you get a computer printout of the forces of the body, it's been proven that typically 85 to 90% of the population can benefit from the use of a properly designed orthotic. We found that through the teaching at the Family Hope Center that the kids who have neurological impairments, anywhere between 90 and 95% of them can benefit from the use of orthotic devices. And that's why Matt is so stringent about getting the kids into an orthotic as early as possible. We've had kids at 2 years old in a little tiny orthotic. The girls in there and the people at the center, kind of giggle when they see them because they're so small. But it benefits the kids in helping them to develop physiologically as well as neurologically. When the pronation becomes too severe, and we can't fix it with just an orthotic, there's a true talar-dorsal dislocation. There is a new procedure out to help correct that. I'm going to bring up Dr. John to discuss this procedure. John, come on up.
Okay, so what happens when the orthotics do not work? Well, unfortunately, that typically means some type of surgical correction. This was the traditional way. When I met Dr. Joe 26 years ago, this is mostly how we would have to attack these things. On the top is what's called a triple arthrodesis. A triple arthrodesis is a very joint destructive procedure. It fuses the three main joints in the back of the foot, and you're left with that lovely hardware in your foot for the rest of your life. The bottom way is called a TTC nail. What the TTC nail is a fusion of the calcaneus, talus, and your leg. So basically there is no further function in the rear foot. So after 26 years, we thought, well, there's got to be a better way. Well, we found one. It's called the hypercure procedure. What the hypercure procedure is a small stent that goes into your subtalar joint. What the subtalar joint is the joint between the talus and the calcaneus, which is your ankle and your heel bone. What happens with hyperpronation in severe cases, the talus will dislocate off the calcaneus and you get the hyperpronated foot. This stent goes in that joint and stops that dislocation. So the way we do it is there's a small incision made on the outside of the foot directly over the joint. This is done through minimal incision surgery. We use a guide wire. We watch it on television for the proper placement. Once the guide wire is in the proper position, we place the stent over the guide wire. The wire is removed, and the stent is an instant cure for the dislocation. On the left, you see a hyperpronated foot. The talus is dislocating off of the calcaneus. On the right, the white arrow is the joint where the stent will be placed, and you see the more normal position. This is about a 2 to 3 week recovery of non-weight bearing in either a cast or a boot. Once that is removed, weight bearing is initiated. And here we'll show a small video.
Do your feet hurt? Have you experienced pain in your knees, hips, or back? Did you know that the leading cause of chronic foot, knee, hip, and back pain is a hindfoot misalignment? Take a look at your feet. Have you ever noticed that your forefoot turns outward or that your arch collapses more than it should? Some people have what appears to be a second inner ankle bone. Others will have the back of their heel turn out more than it should. These are just some of the signs of hindfoot misalignment. The majority of people with misaligned feet never have any pain in their feet. The pain, however, appears to their knees, hips, and back. The foot is the foundation to the body, and a misaligned foot leads to a chain reaction of strain and excessive motion to the knees, hips, and back. Eventually, that excessive motion leads to tissue and joint damage.
So hopefully the video is educational purposes to show you what the advantages are of the hypercure procedure. The hypercure procedure is a minimally invasive procedure that we do in the office under local anesthesia, so there's very little risk to the child. There's no general anesthesia. It takes less than 20 minutes, and the results are instantaneous and they are almost miraculous. On the screen, we have some x-rays here that show how the talus is positioned in these severe talar-tarsal dislocation feet. The talus is actually dipping down and can't be put back into place and held there with just an orthotic. So we have to use the hypercure stent. Here's a slide that shows a child before on the left, the hypercure procedure, and after on the right, an instantaneous and really, really good result from the hypercure procedure. Again, on the left is pre-op, on the right is post-op. It allows the child to walk better, it allows them to get a better toe dig, and again, as Matt discussed, it allows for better neurological development. Okay, so let's talk a little bit about the conclusion and what you get out of this. The bottom line is that we are here as a team to help your children as much as possible and to do it in the most minimally invasive way as we can think of. When we do surgeries, it's all under local anesthesia, it's all in the office, minimally invasive to get the best results possible. In conclusion, this is our contact information. You can reach out to us via email, via phone number, via fax. We want to set up a teleconference if we can to evaluate your child. We want to see them walking on a hard surface in a pair of shorts, walking towards us, walking away from us, so that we can fully evaluate what in fact we could use to improve their overall structure and function. Am I missing anything, guys? Does that sound good? It's been a pleasure working with the team at the Family Hope Center over the past 20, 25 years. Some of the things that I've seen, the changes in the children has been dramatic, and I am sold on the ideas, and it's just been such a pleasure to be here. Hopefully, we will be able to help your child to improve their structure, function, and their life. So thank you so much. Hopefully we'll be able to take some questions now that we see typically in our parent training conferences. Again, thank you. So let's take some questions that we typically get from the parent training conferences. Matthew, you want to act as an audience member here?
Yeah, great. So Dr. Joe and team, can you discuss the complications around children whose hips are dislocating and who have severely dislocated when they come to the Family Hope Center, and even touch on why we find most of the time it's the left hip more than the right hip that's dislocating, and the solutions that you've been coming up with, whether along with our team to support that, but also some of the things that's happening out there that we want to avoid in terms of the surgical procedures.
Good question, good question. So fortunately I have Brett here to help us with the neuromuscular aspect of some of these problems. One of the more common things that we see is a subluxed hip. If you look at this picture on the left side, the femur is just not quite inside of the acetabulum. So it's not dislocated, but it's what we call subluxed. It's just kind of sliding out. Unfortunately, what we see all far too common is a surgical procedure like this, where they cut the femur, they bend it down, and they put a plate and screws on it. Sometimes it's great. The problem is it leads to a short limb, so they kind of walk with a limp. And in this instance, the plate got loose, and it's rubbing against their hip bone. Again, you can see what it looks like when it doesn't particularly work. So we want to try and do anything we can to avoid the necessity for this and get the hip back into the hip socket itself. Brett, you want to talk about how we do that?
Yeah, I mean, it's very individualized as far as what we do for each specific child, but we're trying to avoid destructive surgeries of joints like that. And so sometimes, obviously it starts with the foot a lot, and we work our way up, but sometimes we have to address the ankle, sometimes we have to address the knee. We're also working on gut health and other things. So again, it's a holistic approach. It's comprehensive care. It's not one particular thing. It's looking at the entire patient and figuring out a way to make them as optimized, as their health as optimized as possible.
Mm-hmm. Most of the time, the subluxation occurs on the left side. And we theorize that the inflammatory issues that exist when there are colon problems and impactions and inflammation, that it can affect the left side of the body, and that's what causes some of the changes that we see in the left hip as well. We will do myofascial releases, we will do abduction pillows, we will do vertical suspension. We'll do anything we possibly can think of to avoid the necessity for cutting the bone and putting a plate in. Does that answer your
Right,
question?
so yes, we've worked together on that.
Correct.
We've also done the colon cleanse and good nutrition, get back to crawling on our belly, right?
Correct.
That's the functional way kids get hit.
Which is a big part of it, the crawling.
Yeah, it's
plays
a
big part.
very comprehensive, but as Brett said, collaborative work that we're all discussing. Okay, what comes first? Should we do the colon cleanse? Do we do the abduction pillow? Do we do crawling on our belly more for this particular child? Do we do kind of a soft tissue release in the abductors to loosen that up and have an abduction pillow every night and so on? And Joe, I see you put a slide up here, which is a slide that you've often talked about, how, you know, the first slide was a dislocated hip, and now, you know,
So
almost
if
2.5
you
years.
go back to
Yeah.
this first
That's
slide
what it
that
was
shows
before.
the subluxed hip, this is what it was like before. Then with our program, I'm following the program perfectly, the hip is back into place, this child is running, playing, happy, with no discomfort and no surgeries.
Could I just add something
Of
about the
course.
hardware? It goes back to one of the pictures I had shown with all the hardware in the foot and the ankle. Your surgery may come out perfectly, but if you have all that hardware in there, down the road, there can be an issue with the hardware, which is what you saw here. I mean, the hip was back in place. However, a complication of that type of surgery is issues with the hardware. So although the surgery worked, this child is still having issues, even though they had a more aggressive type surgery.
Mhm. You're talking about the surgery worked in terms of it located the hip but didn't support the function.
Correct.
And so what you three are trying to do is say,
Support
if we
function.
do a surgical procedure, we want it to be neurologically functional.
Correct.
Correct.
I think the other thing is,
John,
you know, what's the root cause of the problem? So that's what we're looking for as well, like you mentioned it, you know, chronic constipation, things like that. So if that's what's potentially causing the hip and musculoskeletal issue, can we fix the constipation first and potentially avoid this? So I think those are things that we're going to look
It's
at.
the team approach that makes the end result so much better. It really is.
Yeah, you have to be able to marry the neurology with the
Correct.
orthopedic. So you three are like almost functional orthopedic, you know, neurological orthopedics, and not just looking at, oh, I see this is dislocated, let's just do this, as opposed to, whoa, let's step away, let's empower the parents, let's teach the holistic approach. And Joe, could you talk about, there are children who have knees that are bent and tight, or their abductors are really tight, and we're trying to support that, and some of the organic solutions. Obviously, we're not looking at surgery as the first option, but a progressive approach. Can you talk about a progressive approach of
Yeah.
lengthening the knees, and even Joe, even talking about how we have some kids who have the tendon guard reflex and they're walking on their toes, and
Right.
after years of walking on their toes, what happens to the Achilles, and what type of myofascial release things that you can do to bring that back into that the children can walk on their heels and
So I'll defer to the knee and the hamstrings and the adductors to Brett, but as far as the Achilles goes, toe walking is another common problem that we see here at the Family Hope Center. Sometimes it's neurological, so it's the tendon guard, as Matt says. We work on that. If the problem still exists, it's actually a contracture or a contraction of the Achilles tendon that needs to be lengthened. Traditionally, a Achilles tendon lengthening is like a Z-plasty lengthening, where they disconnect the tendon, sew it all back together again, and you're in a cast for about 12 weeks. We do a rather simple approach. It's 3 tiny little stab incisions to release the Achilles tendon. We stretch it out. They're in a cast to just above their ankle for 3 weeks, and the results have been dramatic. I saw a 12-year-old boy not too long ago whose mom was related to us, and a pediatrician kept telling the mom that he's going to outgrow it, he's going to outgrow it. And then at 12 years old, the pediatrician finally said, well, I guess he's not going to outgrow it. We did the surgery. 3 weeks later, the child came out of the cast. He was walking perfectly on his heel. Mom started to break down in tears, saying that she felt guilty about not bringing him to us sooner. It's not her fault. But once the surgical procedure is performed, the child is healed, then we go through the neurological development with crawling and getting the kid to function better with being able to plantigrade his foot and stop walking on his toes. When it comes to the hamstrings and the groin,
Yeah, again, I think it really just depends on the particular individual, but sometimes, like Dr. Joe said, there is some need for maybe a myofascial release type of procedure or tenotomy type of procedure. And again, those are small little outpatient procedures and that we do in the office. We try to avoid them and we try to work with the program. We have Matt do the things that they do real well here. And a lot of times that does work, but in instances where it does not work and we need to do something, we do the most minimally invasive type of procedure that we can do with just local anesthesia. There's no general anesthesia, there's fairly almost no recovery, but we're going to try to stretch those things. We're going to try to do rehabilitation and physical therapy type modalities, crawling, creeping, all the things that Matt's talked to you all about so much that are so important. And then when needed, we can do some small things surgically if we have to, but that's usually the last point that we go to. We do not start with those things.
So team, a lot of families will ask a question of how long should I wear the orthotics in a particular day? And I also ask questions like, how long will the orthotic last until I need to either replace them? Like, well, I guess with adults, right? Once you have the orthotic, you're good to go. But if you're a child who's 2 years old or 5 years old or 10 years old, what would be the turnaround on how long that would last and how many hours a day I should wear them? And could you speak to that?
Sure. So the orthotics last 2 shoe sizes in a child. So typically that could be a year, it could be 2 years, it depends upon their growth spurts. They should wear them anytime they're up and about, they should wear the orthotics. The worst thing you could possibly do is walk barefoot. When you're walking barefoot, you're walking on bad structures. So when you're up and about, you're wearing the orthotics. And in an adult, the orthotics are guaranteed for life. Once you get them, if they break, you send them back to us and we'll replace them. Obviously, if you run them over with your car or smash them with a sledgehammer, we won't guarantee them, but other than that, they'll be replaced for free.
Excellent. So how about talking a little bit about how you talk again about how soon I should be adding more and more hours in the day for the children, and if they had red marks on their feet, would that indicate that it's not the right orthotic, or would that indicate, you know what, actually this is excellent because it's actually creating the necessary change in the structure, and you're going to get a callus. So
we have a break-in period. We usually tell the parents to put them in for about 2 hours the first day, add an hour each day after that. It takes about a week to 10 days for them to get completely used to it. Sometimes there are pressure points because they're putting pressure on areas that they've never done before. It's usually on the inside of the foot where that talus tends to drop down off of the calcaneus. If it's really severe, then we start talking about the hypercure procedure. But sometimes a little red spot is an indication that the orthotic is actually working.
Excellent. And Joe and team, could you talk about the shoes? Because some parents want to put the orthotics in a pair of clogs, and I'm always talking about having really high quality shoes, and sometimes even high top shoes. Can you talk to the idea of, if I have the orthotic, which type of shoes would be supporting that whole process?
Again, we do it on an individual basis. Some kids need a high top lace up shoe. Some kids can get away with a low top shoe. So it's an individual basis, but preferably we like the lace up shoes inside the house. Honestly, one of the best things to put an orthotic in is a croc. There's a little ledge on the back of the croc to hold the orthotic in place. It acts as like a slipper, so they're not walking barefoot, and they're still walking on their orthotic.
That's good to know.
Yes.
That's good to know.
So I think in choosing between like a low top and a high top shoe would be the extent of the deformity. The more severe cases, the ankle also turns in with the foot, where a lace up high top would be better. The more milder ones where it just involves the foot, you could get away with a low top lace up shoe.
So I suppose the family can go and get some shoes ordered into the house, as long as they don't break them in on concrete outside.
Yeah.
They could put the orthotic in, walk around the house a little bit,
Right.
see if it fits. If it doesn't quite work, again, the discomfort of the child doesn't mean it's not working.
Right.
It could be that it is working, and the child's a little bit cranky
You
about
always
it.
take
but-
the orthotics with you to put in the shoes when they try them on before you purchase them. Some families actually get 2 pair, one for inside, one for outside.
Yeah, some actually bring it into the home,
Correct.
have them shipped in by Amazon.
Right.
They try it out for a couple of days, and if it doesn't work out, they send them back. So it's a trial and error, and they can also contact you.
Correct.
And talk to
We're
you
always
through it
available. Again,
so that you
contact
can have the
information
best
is out there.
collaborative solution. That's great.
Reach out to us if you need us.
That's great.
I think there's a lot of examples of ones that probably been used, the families have used in the past that have worked well. So we know some of them, you know some of them, so we can absolutely help with that. They can even send us pictures of things they're considering, and we can do that for everyone.
Right, and children that are on our program who come to see us in the clinic, we're always talking anyway.
Yeah, we're always talking.
We're always going back and forth, and
Correct.
we're using our best practices between us to come up with a higher solution. And lastly, Joe, I found that sometimes families will come into the clinic and we'll be lecturing in whatever country we're lecturing in, and we'll be talking about the children, and then a father will come up or a mother will come up and say,
Right.
you know what, I've got these bunions, or you know what, my feet are killing me, and they have that fasciitis.
Yeah,
situation
plantar
going.
fasciitis, yes.
And then you're seeing 2 or 3 siblings and a parent who has been struggling with, some parents will get their foot, in an imprint, and then they take the imprint out. You always talk about how that imprint is just the imprint of dysfunction.
Right. So with
but your method is different
It's
because you're
different.
looking at the dysfunction and you're creating if it's -2, you're going +2.
Correct.
So you're actually looking at a higher level rather than getting. Can you speak to what the orthotics that some practitioners use is they get the foot mold, and then how's that different from the concepts that your team is using?
So if you remember what I said in the presentation earlier, 85% of the population can benefit from orthotics. Typically our kids, it's 95%. But parents will come up to us all the time. I'll talk about heel pain in the morning when they first get up, plantar fasciitis. They'll talk about hammer toes, about bunions. We've designed a whole approach to make it minimally invasive to get the best results. Bunion surgery is very painful. You're talking about cutting bones, plates, screws. We try and do soft tissue releases, put them in a good functional orthotic, and hopefully we've had in some instances the bunions reverse. Again, it's a whole different approach. We also design an orthotic to put the foot back into the anatomically correct position so that the structure improves and the function improves.
Excellent.
And I would say all those things that he talked about leads to all sorts of other issues within the body, right?
Yeah.
That whole foundation first concept. So you can't build a house that functions properly if the foundation is off. So those patients tend to also have knee issues,
Right.
hip issues, low back issues, pelvic issues, spinal problems. So again, we're going to look at all of that, right?
Yeah.
And then how does that affect the rest of their health? So again,
Sometimes sciatica is
it's
due
everything.
to pronation. I mean, sometimes there are conditions that we see in the low back, in the hip, and the knee that could be treated with just something simple as an orthotic or a soft tissue release or hypercure. Again, the most aggressive thing that we do might be hypercure, but again, it's a small incision done under local anesthesia. It's fast, it's perfect, the results are just tremendous.
And also, we end up getting some family members because a lot of the things we treat are genetically passed along due to the foot type. So if the child has it, either a sibling or probably one of the parents also has it. And sometimes that just comes up in the conversation when treating the child.
Right, so they could have a genetic issue, and perhaps they didn't crawl as a baby before.
Right.
And they're doing fine. I
Right.
mean, they
How many adults do we have
Yeah.
crawling on their...
Exactly. Well, they may graduate a couple, but they've
Yeah.
always been pronating
Right.
a little bit too much. So they have the genetic and the functional. And
It's a lot of fun being involved with the Family Hope Center. It's a whole new world of medicine for us, and it's really, really enjoyable. So again, we thank you and the team for having us participate in this tremendous.
It's great to have you three, and obviously those families who are from around the world that are watching it have been really informed with a lot of information. And it's not the end; it's just the beginning. They can
Correct.
contact you, and we're always trying to innovate and develop new ways to help families. So
Yeah.
it's great to have you, and thank you so much for this presentation.
Thank you.
Thank
so
you.
much. Enjoyed the time. Thank you so much.